Hey guys, so today we're going to go over chest trauma for the EMT, or just for your EMT class in general. Let me walk into the screen. That would probably be a good idea. Hopefully this is working. If not, it's going to be very awkward, but honestly, it might be bad to re-record and try again. But we're just going to be doing a quick summary of each condition. I'm not going to go into treatment in this video. I may make another one. But in a lot of cases, there's not a lot we can do because we can't open the chest or give any sort of medication other than oxygen and yeah, that actually might be it. Yeah, for trauma, yeah. And so we're just gonna go over the conditions, and they're pretty simple, pretty straightforward if you know some anatomy. And I guess I'll go over the anatomy a little bit, but that might be a separate video to just know everything from the pulmonary system and just generally where the heart is and how the blood travels from the heart to the capillaries, wherever it's going. And we're gonna start. So maybe I'll just leave this aside somewhere. Sorry, this is the first one. This is the first video. Oh, check that out. Anyways, the first thing we're going over is pneumothorax. And a pneumothorax you can basically tell what it is from the name. So pneumo, meaning, I think it means either lungs or air, and thorax, meaning thoracic cavity. And so this is where you have air in your thoracic cavity. And if you remember, you have this is supposed to be my drawing attempt of the thoracic cavity, where you have your lungs, and you got your heart. Your other lung is kind of a little bit smaller on your left side. And so you got this cavity, and you have two linings that essentially make up the space between the outside of the lung and the walls of the cavity. So there's one lining on the wall of the thoracic cavity, and that is the pleural membrane. And then you also have the lining that's on the lung itself, and that is the visceral membrane. And yeah, so I'll just read that. Okay. And essentially what this does is the space between the two is very, I don't know how I learned it, but it was essentially very tight. So when one moves, the other moves with it. And the point of this being, that's why your lungs actually expand and contract. So if these weren't connected, if they weren't tight, I don't know how to describe it. I might include it in the description. So if there's any other corrections or something, check the description. But the general idea is they move together, and that's why when you're having trouble breathing, you can actually physically see the lungs moving. Otherwise, the lung would just be moving on the inside, and you wouldn't see any chest rise or fall. And so in a pneumothorax, we have air getting into that. So there's usually some sort of puncture, or actually, you can actually have it. Can you have it from sepsis? I don't know if you have it from. You can have it from forced trauma or sepsis, or pneumonia. Although I don't know how exactly that would happen, but I wrote it down, which I didn't go over that too much. But the main thing is trauma, because we're covering trauma. And so you can have a puncture, and that will bring air into this space, and it will change the pressure so that now there's pressure coming in, and that's going to push the lung sort of to the side. And when that happens, everything sort of gets pushed to the side. So what was this now becomes pushed. So in this case, we have the opening in the pleural cavity on the right side, and so everything's going to be shifted to the left. So you might see this, so the lungs kind of collapsed a little bit, and you might see the trachea and the bronchi sort of moving to the right. And this is called tracheal deviation, and it's one of the biggest signs of a pneumothorax. And essentially, when you have enough pressure that causes bigger problems, you get a tension pneumothorax. So this is a simple pneumothorax, but once it gets, well, actually neither of these. This would be like a tension pneumothorax because it's pretty serious, but. And this is because the tension caused by the air pressure coming in is offsetting everything else. And so in this case, you will have some signs and symptoms, and these are increased heart rate. You will have decreased blood pressure, and the decreased blood pressure is because of shock, because you have obstructive shock, because there's something physically stopping the heart from expanding. And I believe the heart rate's just because you're compensating for that, because your blood pressure is low, so you're not perfusing as much, and you're not getting enough like new blood into areas, so your heart's trying to pump to make up for that. And yeah, so I forgot. So this area here, you can see we have two lungs, right? So we got lung number 1 and lung number 2. So this the right, the left. You got like the heart sitting here, and there's like this area in between, and this area is called the mediastinum. Media meaning middle, sternum, not too sure what that means actually. But what's in this mediastinum is the heart. You're gonna have the heart. You're gonna have the trachea. You're gonna have the aorta, which is the main large blood vessel coming out of the top of the heart. And if you remember from anatomy, your heart kind of looks like this, something like that. And then you have this aorta coming from the left ventricle, and it sort of comes around up here, and we have this thing called the aortic arch, and it sort of comes around and it goes down behind. And there are actually some trauma cases where the aorta like gets pushed all the way into the other side, so it becomes on the front, and that is, I mean, I guess it's not the worst thing. We're going to cover worse things than that, but that's not good either. And another thing is, I believe the aorta is on your right side. So if you're looking at the body, let's say this is a human person as opposed to a non-human person, I guess. Your aorta is on the, I believe it's on the right side, and this is why when you have a pregnant patient, you want to move the baby to the left to stop the hypertensive syndrome. So the baby, when it's growing, when it's really big, it can actually put pressure on the aorta. And I'm forgetting what the name of the hypertensive syndrome is. Neonatal hypertensive, I don't remember. But the point being, the aorta is on the right side as it's going down, and the inferior, no, I lied. The aorta is on the left side, which makes sense because the heart is on the left side. The inferior vena cava is on the left side. And so you're trying to move the baby off of the inferior vena cava, because when it's on the inferior vena cava, blood can't go back into the body. So you're moving the baby from the right side to the left side physically, and by doing that, you're taking pressure off the inferior vena cava, which allows blood to go back into the right atrium and just get back into circulation. And remember, the inferior vena cava is the last part of the whole like blood system when it's coming back. That's like the last step to coming back. It can come either through the superior vena cava or the inferior vena cava. And I think the only ones that don't go back through that specific route is like coronary veins, because the coronary veins just go around the heart, or like through the heart tissue. I'm forgetting which layer exactly, but it goes essentially around the heart tissue, oxygenating the heart muscles, the myocardium. And so yeah, sorry, I was getting confused like which one the baby was putting pressure on. But anyways, back to pneumothorax. Crazy side tangent there. So you have tracheal deviation, and that is a late sign of tension pneumo, and that's when you know it's serious. I might put in the comments what's the difference between simple and tension, but tension is really where I remember like it's serious. You've got air in the pulmonary cavity, pleural cavity, sorry. The pleural cavity is the space between the pleural membrane and the visceral membrane that is the one that goes right attached to the lungs. And remember, I think it's like negative pressure between those two, which is why they expand and contract together. So like your skin moves with your lungs, like your lungs aren't just pumping up, like up, big and small, and your skin's just staying there. Like your skin actually moves with it. And that's really nice because then we can like check for flail chest and other stuff that we're gonna cover. But anyways, we're not gonna cover like oxygenation here because it's sort of dependent on how they are and how much they're oxygenating, but and how difficult their breathing is, which is gonna change as it goes from a simple pneumo to a tension pneumo. But the main thing is you're gonna put an occlusive dressing, and occlusive dressing, if you don't remember, I don't know if they make fancy ones, but the way we learned it was you have like a gauze, not gauze, it's like a seal, and then you have tape on it on like 3 of the sides. And the nice thing about this is that when air is moving outward, like let's say there's air trapped in your lung cavity, which there's a lot of it in this case, if it wants to move outward, like let's say the right lung is trying to expand out, right? But there's the air, so if it's pushing against it, the air will come out of the occlusive dressing, but it won't be able to go back in. And that's the nice thing. That's why we tape it on 3 sides. So it's able to escape, but it can't come back in. Hopefully that makes sense. You can find a video, I'm sure, but I'm kind of hoping that makes sense because we're not going to go too much into treatment. And yeah, I think that is most of what I want to cover for pneumothorax. Next, we're going to cover hemothorax. But before that, I'm going to take off my jacket because it is so much hotter than I thought it would be. Okay, we're back. Hopefully that wasn't too fast. I'm kind of a lazy bum and I don't want to edit stuff because I'm just not good at editing, and also I'm lazy. More so the lazy part, not the editing part. But anyways, we're back, and right now we're going to do hemothorax, and it's about the same thing, but instead of it's actually not the same thing at all, but there is a similar mechanism involved, which is your lung is going to possibly collapse, and the main thing is it's not going to be able to expand fully, and the reason for that is you have blood in your lungs. So pneumothorax is pneumo, air, thorax, in the thoracic cavity, and in hemothorax you have blood in the thoracic cavity, and that's putting pressure on your lungs so they're unable to expand, and yeah, it just causes a bunch of problems. And you're gonna have probably somewhat similar symptoms. It's gonna be kind of hard to tell that the blood is actually pooling in the lungs. Kind of depends on how severe and how quickly the onset is, but you're going to treat it in somewhat the same way. If there's a puncture, you're going to have the occlusive. Basically, if there's a hole, you're going to put on that occlusive dressing, and you're probably going to help with some oxygenation. I need to double check if CPAP is required there. Yeah, so hemothorax is blood in the lungs, and this has to be treated with a not pericard, some sort of tube. Essentially they put a chest tube. I'm forgetting the science name for it, but they put a tube cut into your lung, into your thoracic cavity, and they have to suck out the blood. And the same is done for tension pneumo. So for tension pneumo, if you have a lot of pressure stored up in the lungs, in the thoracic cavity, they will put a needle in to decompress that pressure and hopefully let your lungs uncollapse. I don't know if it can actually uncollapse, but just decrease the pressure on that lung so that if it's diminished lung sounds because it's not expanding fully, hopefully now it can expand a little bit more because there's less air pressure or pressure from that open wound. So that's that, and I didn't really have too much for chemothorax. It's just blood in your lungs that will cause probably crackles. You'll probably hear maybe absent absent lung sounds. You might be able to hear crackles because of the water, but that's more so for pneumonia. And water in the lungs, this is sort of water in the in the pleural space, so I guess you really wouldn't hear crackles. You're mostly going to hear just absent or diminished lung sounds. And so that is everything I have for pneumothorax. But now we get to the fun one that is going to be on the exam if you're taking the EMT, and that is the one we identify from Beck's triad, the one and only. I kind of want to like announce this as like a WWE like mic guy. The one and only, the 3-time, what's the name? Beck's triad winning. It's cardiac tamponade. It's the one in the movie. It's the one from the pit. Cardiac tamponade. And this is really interesting because obviously you got your heart. Kind of looks, that is not how it looks, something like that. And around that there is a sac, and that's the pericardial sac. And in this case, you likely have some sort of perforation, which just means like an opening in one of your arteries caused by some sort of puncture, or some other means, maybe some shear force just from trauma, or from coming to a stop too fast. It's because when you come to a stop too fast in a car, your heart is actually like not super secured. I mean, there's bones on both sides which help protect you if you get like punched in the heart or in the chest, but they're also not great because they cause you to hit them when you slow down. So you got your heart here, you got your chest walls here. This is your like sternum, and then this is your like back. And so when you stop too fast, you might get that like movement back and forth. It's kind of similar to like concussions, where you get hit and you go back and then you come back forward, and then that's just terrible. But the skull also helps you, so it's a trade-off, but there are pros and cons. But the point being, the wall can actually damage you as you come hit it, and then can cause like an artery to rupture, and that can cause blood into your sac, which is the pericardial sac. And when there's blood, it's kind of similar to the lung thing, but it's now in the pericardial sac. It's not the hemothorax. Hemothorax is blood in the thoracic cavity, which is around the lungs. Cardiac tamponade is blood in the pericardial sac. So instead of diminished lung sounds like in hemothorax, you're going to have diminished heart sounds. And that is one of Beck's triad. Oh my goodness, the thing. He said the thing, it's Beck's triad. And this is narrowing pulse pressure. I'm going to just put BP / hypotension. Apparently some people learn it as hypotension. We learned it as narrowing pulse pressure. It's both, I think. But the narrowing pulse pressure just meaning like if this is your like systolic and this is your diastolic, I know there's a name for it. I don't remember the name for it, but it's gonna like decrease. So the numbers are gonna come closer together. And then there's muffled heart sounds, because obviously there's a bunch of liquid around the sac that shouldn't have much of anything, except maybe like there's probably some sort of shock absorbent fluid, but not blood. You should not have blood. So muffled heart sounds. And then my brain's not functioning. Ooh. Okay, I'm gonna cheat a little bit. It's JVD. Oh my goodness. JVD. And the reason for this is you have obstructive shock. Obstructive shock is when there's something like physically stopping your heart from fully expanding. And when that happens, your atrium is not able to like move enough blood. So normally that is not right. This goes to the lungs, comes back this way, then goes here, then goes out through the airway. Okay, that was unnecessary. I'm not new, I'm pretty new to teaching, okay? So I'm sorry, forgive me, but we're gonna keep on going ahead. We're gonna keep on moving. But the reason for JVD is your preload is decreasing. So the blood that like gets into your left atrium is not as much as before because of this blood. This is all blood. I probably should have mentioned that. that's all blood. So the blood is like stopping, it's obstructing your full refill, your full preload, and that means you're gonna have a backup of fluid. Well, you have blood going to your head, to the circle of Willis, that's just the thing that like oxygenates your entire brain, and then it comes back through your jugular veins, and let's say now your heart has a problem where it's not getting enough preload, or it's not able to preload as much as it's not able to preload as much as it used to. What does that mean? Well, that means that there's going to be backup. In that case, that's going to come up in your jugular veins. So you're going to have like big Ronnie Coleman looking veins, but unlike Ronnie Coleman, that is not your baseline. You are not meant to have huge, giant jugular veins. Unlike, actually, I don't know how many times you won Mr. Olympia, but we are not Ronnie Coleman. Most of you are not Ronnie Coleman. But so those big veins are just proof that you are not getting that full preload because of the obstruction, which is the blood, i.e. cardiac tamponade. And that's kind of all you need to know for that. This is the one I was thinking about before. To treat this, the doctors in the ER are going to poke a needle into that space without trying to, touch the heart, because that would be bad. And then they have to like straight up draw the blood. It's the coolest thing in the movie. It's like, they're like, oh no, I might, have nicked an artery, but not like an artery on the heart, like a coronal artery. And they're like, oh shoot. But then they're like, miraculously, they didn't actually nick it, and it actually got in the right place, and then took the blood out of the sac, out of the pericardial sac. And that is called pericardial synthesis. There is no shot that I'm spelling that right, so I'm just not going to spell it. But yeah, that's everything I had for my first page. There were more pages, so don't get your hopes up, but we went over cardiac tamponade that reduces preload, and I forgot to mention, I have it here on another sheet of paper, but it increases your heart rate. It's going to decrease your blood pressure, so sort of similar stuff as the hemothorax, but yeah, so, and it kind of makes, sorry, not the hemothorax, as the tension pneumothorax. You're going to have increased heart rate to compensate for your decreased blood pressure, and the blood pressure is decreasing because blood pressure is the amount of force of the blood on the walls of your vessels, and when you have less blood, you have less force on the walls of your blood vessels, and so your blood pressure is going to decrease. And it makes sense because tension pneumothorax is air, not really air pressure, well, it is the pressure from the air caused by like the hole in your lungs usually, or pneumonia, which I don't actually know how that works, but usually the hole in your lungs, and that causes everything to move aside, kind of like blocks the heart from like fully preloading, fully expanding and contracting. Well, not the contraction would be fine, but fully expanding. And similar here, the blood stops it from fully expanding. I feel like I'm beating a dead horse at this point, so we're gonna keep going. And so yeah, that is kind of everything I had. Oh, no, that's everything I had. There's just one thing I need to check, but should be fine. I think what I wrote down was 10 to 40% of people with Beck's triad are diagnosed with cardiac tamponade. Might need to double check that, but I'm pretty sure that's right. The main point being, if it's Beck's triad, it's probably cardiac tamponade. But it could be other stuff, according to my notes, which not really the most important thing to know. So I'm not gonna fix it right now. I will find the answer to that and hopefully put it in the comments. Or if you know it, put it in the comments for me. I really should have looked into this, but yeah. So the next thing, really small, it's just myocardial contusion, and this is a very similar mechanism of as you're coming to like fast deceleration, your heart might smack around in your chest cavity. One of the arteries might burst or shear. Shear force is generally just when two things are moving the opposite direction, and that causes them to have like the frictional force here and break. So in a myocardial contusion, that is where that happens to a cavity, or not a cavity, the coronal artery, and then you'll be bleeding in your pericardial sac, and that will probably lead to cardiac tamponade, which we learned about. We know that now. And I've got a table, which I need to write down. Do I have space? No, I actually do have space. So we're going to go over the 3 differences between cardiac tamponade, we're just going to write that, and intention and pneumo. We'll just leave it there. So there are 3 big differences to actually recognize the 2. So for both, you're going to have respiratory distress, because in the case of cardiac tamponade, you've got oxygen. You've got decreased oxygenation because you're just moving less blood because of all that blood that's in the pericardial sac stopping preload from happening as well. And in tension pneumo, you have the lungs obviously not able to fully expand, so you're not going to get good oxygen carbon dioxide exchange. So in both cases, you're going to have like respiratory distress. Your neck veins are going to be distended in both cases. Because tension pneumo, you've got the pressure from the air in the lungs, in the pleural cavity, and then similarly, we talked about it just now, JVD and cardiac tamponade. I'm not going to go over that again because that would be repetitive. So next, we're going to go over the trachea. Trachea is the main thing that is going to be really different. So in cardiac tamponade, your trachea isn't actually affected in any way, usually, assuming there's not other problems from whatever the MOI was for the trauma. But generally, if it's pure cardiac tamponade, your trachea is going to be midline. So trachea, midline, and then in tension pneumo, it's going to be deviated because everything in the mediastinum, which is that middle with your heart, with your trachea, and with your aorta, all of that's going to be pushed to the side due to the tension, due to the pressure change that is moving everything to the unaffected side without the puncture. So your trachea is going to be deviated. So your trachea normally looks like this. Now it might look like that, coming into your coming in from here to your bronchioles, your bronchi. So it's going to be slightly shifted. And the second big difference is going to be breath sounds. So cardiac tamponade, again, this just had nothing to do with really like the lungs too much. So your breath sounds are going to be okay. They're going to be probably a little bit faster, but they're probably going to be normal sounding. But in tension pneumo, they're going to be absent or decreased. And then finally, heart sounds. And this all hopefully makes sense to you guys, given the mechanisms that we've talked about so far of like how this stuff happens. But through heart sounds, the main thing is going to be cardiac tamponade obviously have muffled heart sounds. That's part of our Brecht's triad, muffled. And then tension pneumo should be fine. So normal heart sounds. Although there might be some obstructive shock. Not obstructive, well there is going to be obstructive shock, but it might not be perfectly normal, but it's not going to be as bad as, biggest thing about it. So in tension pneumo, you've just got pressure pushing everything to the side, but your heart's still beating somewhat normally. But in cardiac tamponade, you've straight up got blood right there in the pericardial sac. So it's going to be a lot more muffled than compared to tension pneumo. And that is all my notes for those two. Now I've got some like random smaller diseases. I watched this guy I should probably put my sources down below. I've got like 2 or 3 sources, and but this is sort of like paramedic stuff. I never learned about this in EMT school, but we might still go over it because it's interesting. I guess we'll cover it really quickly because I don't think you need to know it. And but yeah, these are sort of extra, and they're probably good to know them. But just to know, like pneumothorax, simple versus tension, pneumothorax, cardiac tamponade, Obstructive shock are probably the main things you need to know in this case. Beck's triad, and that is muffled heart sounds, nearing pulse pressure, and jugular vein distension. And yeah, so those are probably the main things you need to know. But we can still go over this because I thought it was pretty interesting. Realistically, there's probably not a whole lot you can do for a lot of these. And I might just not write down all of them. There's some that kind of require a larger explanation, but the main one we covered already was myocardial contusions. That is just when one of the arteries, the coronal arteries, bursts. And a pretty rough thing about that is they can actually get into, like, the blood in that area can actually get into the tissue surrounding the heart. And that would be very bad because it can cause edema, it can cause swelling in that area because the blood can actually enter the cells. So in hemothorax, your blood is just there, it's just in the sac. It's not really entering into the cells. At least not as much, but in myocardial contusion, your blood can actually enter into the cells around the heart. That can cause edema and probably some obstructive shock as well. And some stuff that can complicate it is ectopic activity. And this is just where, so this would actually require longer explanation. So your heart looks something like this. Not the best art I've ever done. Actually, that looks pretty nice. But we have some nodes. So your heart's essentially like an electrical circuit box. And you've got like three main things. So you've got this node here, which is called the SA node. You've got a node down here, which is called the AV node. And essentially the SA node tells the AV node to fire. And then the AV node sends a signal down here through the, I'm forgetting what the name is, the intervertebral septum? I'm forgetting what the name is, I didn't prepare for this. This is kind of on the fly, if that makes sense. But essentially you have wires going from the AV node around down to the apex of the heart at the left side. And remember, patient's left, so this is the left, even though it's technically the right on our side, but patient's left is where the apex is. So the wires go down to the apex, come back around, and the point of this is all so that you get the contraction at the same time, because remember, you want the blood to leave the right ventricle and enter the lungs at the same time the blood is leaving the left ventricle and going out to the body in the aorta, through the aorta. And you want those at the same time so that when one loses the blood, the other is bringing the blood around, so that the blood from the atrium is coming back down and the blood from the ventricle is able to go around at the same time. And that just keeps everything in sync so you're not like backing up blood one way or another. But the main thing here is there's this pattern. So you go from the SA node to the AV node and the AV node into the rest of the cardiac muscle surrounding the ventricles. And there are names from this. I think this is called the bundle of His. That's through the wall between the ventricles, and then the coming back around, I think, is called the Purkinje fibers. But I might be wrong, but I think those are right. Those sound right to me. Either way, the main point of all this was ectopic activity. If you know what ectopic pregnancy is, that is where what are we at? What stage are we at in that case? We are at zygote. So that is where the zygote implants in the area. Actually, wait, it's the ovum, isn't it? Yeah, it's the ovum. So the ovum, the fertilized egg, implants somewhere where it's not supposed to, usually the fallopian tubes. And so you're getting a placement somewhere you're not expecting it. Similarly, in this case, with ectopic activity, when in terms of like heart electrical activity, this is where the AV node is actually sending signals to the SA node. So it's kind of going backwards. So it's just a weird signal coming from the wrong place. So kind of similar idea there. That's why the word ectopic is used. I forgot what it actually means in like the Greek or Latin. But generally the idea is that you're getting the signal from the wrong place or you're implanting in the wrong place. Next, we have myocardial rupture. It's kind of similar. It's perforation of core heart structures. So this can be sort of bigger things than just arteries. This would probably include like atria, which would be really bad. I think the fatality rate for this is really, really bad. Next, a more interesting one, we have commodio cordis. Commodio. I'll spell it. I can't say it. This is how I feel when I learn new languages. I'm kind of like nervous to say it, especially if it's like to a native speaker who's like doesn't know that I'm learning it and isn't like, oh, he's learning it. He's prepared to hear my absolute horrendous pronunciation. But commodio cordis, COMMOTIO, cordis, and this is where the cardiac arrest is caused by a blow to the heart. Sorry, I had to jog my memory. And this is the case where, like, if a baseball hits some kid in the heart at the right time in their cardiac cycle being something like this. I really should not go over this right now. Nope, that is a whole nother story for another day. Anyways, sometime in that cardiac cycle that we're not going to talk about, you might get hit by like a baseball. This is the baseball, not, it's obviously not actually hitting the electricity. That doesn't make any sense, but hitting the outside chest wall, that can cause a problem. And this is where an AED or defibrillator would probably be pretty nice, because just to get that rhythm back on. I hope that makes sense. I don't know if that explanation, that's more of a paramedic explanation. Go ask a paramedic near you, but that's the general idea. So that cardiac rhythm, that electrical rhythm, which is usually like just set in your heart most of the time. Your AV node has like a baseline rhythm of like 40 to 60, and that's totally like internal to your AV node. So that's not, so you know how like your heart can like beat faster or slower depending on like how excited you are, how much. There's a lot of chemical stuff that goes into that with like baroreceptors and like pressure receptors to make sure your heart is pumping enough, but I don't really remember that. But the general idea is you can go up or down based on your body's needs. Your AV node actually has like a baseline rhythm, and I think it's 40 to 60 hertz or beats per minute. And so that's just going. And so you have that normal cycle going on. In this case, the baseball, the puck, whatever it is, maybe the karate chop, I don't know how that would happen, but whatever it is, it's breaking that cycle and leading to cardiac arrest. And that can cause unresponsiveness, apnea, loss of pulse, cyanosis, and possibly a seizure. And yeah, next we have a really interesting one, which is going to get us into another side tangent, but it's such a fun side tangent. So like, hopefully this isn't like, I feel like this might not be the best like simple explanation, but I feel like I'm kind of presupposing a decent amount of knowledge of like anatomy and physiology, but I think you should have covered that, hopefully. Let me know if this is too fast or slow, and hopefully you didn't hear me just like gulp that Coke. Perfect, okay. So, traumatic aortic disruption, and this is a disruption or rupture of the aorta, which is a huge blood vessel. I think it's where most of your blood goes outside of the heart, except for obviously coronary arteries, which go around your heart. But this is where your aorta ruptures. So your aorta is that big pipe. So you got, I'm gonna get so good at drawing hearts by the end of this. You would think. You would think, I think I got worse. But you've got this thing coming out attached to the left ventricle, and it looks something like that. I feel like it's over here. And you got these little large pipes that go to other places, and then it like comes back around and it goes to your arm. So lots of stuff going on. Main point being, that has a lot of actual layers inside. So we're gonna draw that. That can be the middle, big, small, and it's gonna look something like this. Hopefully this doesn't look too complicated. And the smallest is called the intima. And this is just endothelial cells. These are just, it's a very like thin cell layer, and it's just sort of like a lining hopefully that's not a horrible explanation of endothelial cells. Main reason they don't have too much functional, I feel like I'm lying there. So we're just gonna leave it at that. It's just the shortest layer, relatively skinny layer there of cells. They're just meant to line the cavity, and also these are the ones that are in direct contact with the blood. Next is the media, so intima media, hopefully I'm saying that right. And this is the smooth muscle and elastic fibers. And this is also includes fibroblasts, which is a cell type that secretes an extracellular matrix. And that's kind of like, it's kind of like this gooey stuff. I don't know if it's actually gooey, but it's like this liquid sort of gelatinous substance is always how I've thought about it. And essentially that just like holds everything together. It's kind of like if you put stuff in Jell-O, it like suspends everything. And that's generally how you should think of the extracellular matrix. So fibroblasts are actually the ones that secrete it, so they produce the extracellular matrix and that secretion, that fluid. And finally, it also the intima media is also the one with most of the myocardial muscles, the smooth muscle. And then you have the intima adventitia. You might realize I do not know these names. You probably do not need to know any of these names by heart, but it's cool to know. And this is more of like a side tangent. You really probably don't need to know this for your EMT, but these are thick and include collagenous fibers. So very thick, collagenous. I'm not gonna write that, fibers. That sounds like cerebral fluid. That is not cerebral fluid. That's meant to say collagenous fibers. And I think that's actually most of what I have. I've got some stuff on like diaphragmatic injuries of your diaphragm. I've got some stuff on like esophageal injuries and some great vessel injuries, so your large blood vessels around your heart. If those rupture, you're in big trouble, and you probably need surgery very quickly. And I can't imagine the fatality there, but I'm assuming it's not very good. But yeah, that's kind of everything I had. The last kind of word that was interesting is a hematoma, and that is a collection of blood or a packet of blood that's been clotted, and it kind of creates like a sac. Yeah, so that is just a hematoma is just a collection of blood, and you can probably see it in bruising or something like that. And yeah, that's kind of everything I had. You know, I'm realizing this teaching thing is harder than it appears to be. So it was fun though. Hopefully this made sense. Let me know if I got anything wrong. I think most of it was pretty good and solid, but there was a couple of things that I missed. But that's everything I had for you for today. So thank you for watching. Stay faithful, stay focused. God bless.